Dr. Brianna Partee, who is a doctor of physiotherapy. And she's going to help put you on the right track. This is a first year class. And they finally got some sense and put it where this information should be, but begin at the beginning, I always say. So you can see on the back of your attendance sheet a little questionnaire that we did with the third year guys, and there's some excellent data. I think it will be on Canvas. I'll show it later on in the second half. And so we want to see sort of baseline where you folks are in relation to pain and discomfort. And worked in the laboratories and not necessarily ideal seating situations, and so we recognize that. But some of you did have some complaints about discomfort in the back, which isn't surprising. So, without further delay, you're on, Brianna.
I'm on. All right, guys, I know it's early. Just bear with me. My style is very much like if people have questions or you have comments or you have something to talk about, feel free to raise your hand or shout it out and we can kind of discuss what your experiences are related to the information that I'm presenting today. So I know that most lecturers, they come in and they give you some objectives, but I think my main take home is that I've been practicing as a physical therapist for almost 8 years, and I've seen a lot of medical dental professionals, from maxillofacial fellows to orthodontic residents to dental students to just dentists. In one of my lectures, I think like a year or two ago, there was a kid who was in dental school here, and his dad had been a dentist, who was my dentist. And he's like, oh yeah, my dad just got a cervical fusion because he's having a ton of neck pain. So this information is really important because he does a lot of the stuff that you presented today to keep his neck pain gone even after surgery and his radiating symptoms that he was having before surgery. So hopefully you guys find this useful today. Like I said, if you have any questions, feel free to shout out and we'll discuss. But here's my main objectives is understanding the role of a physical therapist. A lot of times people are not really sure what we do. They think we give good massages, which could be the case, but it's not really how I focus my plan of care. But mostly we in your population of patients or the patients that you treat, we assist in decreasing the risk of cervical, TMJ, or TMD, the dysfunction of the TMJ, with low back pain and shoulder pain. I think that a lot of, when I come in other lectures, dentists didn't even know that a physical therapist could treat the TMJ or the dysfunction of the TMJ. And we do have physical therapists that have specializations in that or that treat that very frequently. There's a private practice in Beechwood that mostly treats it. I have a colleague who most of her caseload is all TMD patients. So it's a good kind of referral source if you're going to be here to know that there are physical therapists that treat that. I want you guys to be able to at least discuss common biomechanical seating issues. I think that Dr. Ochenero talked about how some of the seating you guys have, some of the ways that when you guys are learning are not the best, and people have been complaining of back and neck pain. So at least if discussing it is important because it's going to be challenges even when you're out of school. You may be on a rotation, you may be in a new clinic, and that's where you take a job. And they're not going to necessarily buy you the perfect chair or the perfect station, and you're going to kind of have to be able to adjust yourself unless you open your own clinic, which that'll be years down the road. I want you guys to be able to accurately demonstrate some exercises utilized for improving postural muscle flexibility and strength. A lot of times pain is not necessarily correlated with posture, but sometimes muscle flexibility, muscle strength, muscle stability is also incorporated in that. So I'll go over some exercises today that you can quickly do if you're on a long case with a patient that's difficult and you're starting to have some stiffness in your neck or some radiating symptoms. That you can literally say, oh, I have to grab something. You can walk away from the patient for a second, quickly do some of these exercises, and then go back and reposition yourself. I want you to be able to identify the role of a physical therapist as a musculoskeletal and functional movement specialist. And I'll talk about a lot about how I do that. And we're going to do some verbal participation through exercises and kind of cases to kind of talk about how I evaluate a patient and kind of how you guys are going to look at yourselves as patients so you don't have issues down the road. And then correctly demonstrate some exercises utilized to improve core stability, strength. Mostly we'll just review these if people have questions or they have things that they want to go over or things they've done in the gym that they want to discuss. We can also discuss that at that time. I know you guys don't have a lot of time. You're studying, you're working, you're going to be studying for boards and doing all that stuff. So there's people in your program that probably do a lot of exercising and people that are more sedentary. So we need to kind of come to a common ground in doing some sort of exercises and getting the most bang for the buck, just in the clinic or when you're in the library, things that you can do to kind of increase the stability of your core, your shoulders, all that stuff, and decrease the stresses on your spine. All right, I'm going to have somebody read this case study aloud for me. So somebody should just volunteer, or I will choose somebody to read it. Okay.
30-year-old female dentist who went to University Hospital with LV, cervical pain, and mild wrist pain. Before starting her dental fellowship in orthodontics, patient reports she had a history of lower back pain when working in a research lab at St. Louis University, where she sat on the lab bench looking at a microscope for 2 to 3 hours a day. Since starting this fellowship, the neck pain has become unbearable. She also reports that she is constantly texting her long-distance boyfriend who lives in Chicago and believes that this has also contributed to her symptoms.
Okay, so her examination, when I evaluate her, reveals decreased range of motion in cervical spine, scapular weakness, and patient describes the pain as intense and rates the pain at 7 out of 10. And it progressively has worsened over the last 2 months. Pain is often present at night and interferes with sleeping in long cases in the clinic. So a lot of the patients that I've seen, they're okay throughout the day, they feel it a little bit, and then once they stop studying, they lay down in bed, they start watching Netflix, they kind of unwind, is when the pain starts to really increase. Where does this patient need to be referred? Come on, guys. Yes, physical therapy. Yes, this patient needs to be in physical therapy. And I'm sure that if we raise our hand, has anybody had a bout of back pain since starting college or grad school? Yes. Has anybody had any neck pain when they've been working with a patient or just in school, college? Yes. So a lot of the cases that I see in the clinic, these people say, oh, well, I went to the doctor, I tried ibuprofen, I did muscle relaxers, and it's been 8 months since I had it. It's like, that's when it becomes a chronic issue. So a lot of times it doesn't take me that long to evaluate where your impairments are, where the strength issues are. I can get you on a quick program, and then it doesn't become a chronic issue. Then you only have a few weeks of pain, and you can get on a better track of doing strength exercises, some active warm-up stuff before you see patients, so you don't have that 7 out of 10 pain at the end of the day. All right, smile. Being a dentist does not have to hurt. As dental students, I think that I don't know how much ergonomics class and lectures you've had. I know you're going to have one today. But we really need to pay attention. A lot of times when I learned about ergonomics, working with patients, I'm like, yeah. I need to figure out what I'm supposed to do with the patient. I'm not going to worry as much about my posture and my positioning and all that stuff. But as you get older, you should really pay attention to how you position the patient, and that's even, you can raise the patient up towards you so you're not leaning over as much. And just how you're holding the instruments, and how you place all your instruments around you. So setting up where you're treating a patient, I have to do that too. Raising the table up, making sure that everything's there so you're not reaching, getting up, changing positions, and you can be in a good position for your neck, your back, all of that. So just being aware, this is something that's very important. Maybe not for now. There's people here that would probably raise their hand, I don't have any neck pain, I don't have any back pain. I'm getting A's in all my classes, I'm gonna be a great dentist. But it's really when you're 40, 50, that things can catch up with people and you're not able to be as active in the gym, you're not able to do as much. So kind of setting up good habits at the beginning is gonna set you up for success. I know that case is really expensive, my husband went here, so you spend hundreds and thousands of dollars to go to school. You don't want to shorten your career because of a musculoskeletal issue, or you can't practice, so you have to get surgery. So that's why this is really important. If we're spending all this money for school, or if your parents are spending all this money for school, or whatever it is, that it's really important to take these things seriously so you can have a career that's less painful than it could be, or not painful at all. Okay. So, my role. So, I think this is really important for you guys to know, because I think that there will be people here in this class that probably need to be in my clinic soon, and just sending patients that have some of these issues to a physical therapist is something that you'll be able to do in the future. So, I diagnose and treat individuals of all ages to improve their abilities to move, perform functional activities in their daily lives. Now, a lot of times my plan of care is not always focused on just decreasing their pain, because pain is very multifactorial. If they have a lot of stress, if they've had trauma, and those things aren't addressed, I can get them really strong, I can get their spine moving, I can do all of that, and the pain is still there. But my goal is to get them as most functional and closer to their baseline as they were before. So that's something that I really focus on. It's not always pain focused. But in the terms of seeing dental students, orthodontic students, medical students, usually by the end of our treatments, if they're consistent with their home exercise program, they're consistent with the plan of care, they come and see me, they do what they're supposed to do, the pain goes away. So I develop a plan of exercises, manual techniques. I actually, in the last year, I do some dry needling. Is anybody familiar with dry needling? Some people. We can talk about it more. But a lot of times, med students, just grad students, PhD students, they have a lot of tone and trigger points in their upper trap, and I use a needle to release these trigger points in the muscles. And once you release that muscle, then the whole periscapular and the whole postural muscles can work better, and it's not overactive. We think about it, we're on our phones, we're on our cell phones, we're on our computers all day, and we're in this rounded posture, and that puts a lot more stress on your upper trap. And that's something that you're going to be using all day when you're working on patients, so making sure that the upper trap is flexible and has a correct length tension curve is something that, like, I do some dry needling and the patient says my neck pain is gone. So that's something that I do. I do some modalities to improve movement. There's not really much there's not very much research on ultrasound, but there are some physical therapists that, if something's very acute, they use ultrasound to calm down some of the tissues, and people say it's helpful. I like to practice research-based, so I don't do a lot of ultrasound, but if it's prescribed, they do use ultrasound on the TMJ to decrease some of the inflammation, and that's something that's commonly used, and it does work with that patient population. Basically, I want to improve movement, reduce pain, and restore function, prevent disability. Therapy settings include hospitals, outpatient neurological clinics, private practices, outpatient orthopedic settings, home health, nursing homes. I work in a hospital-based setting at UH on the 4th floor, right across the street from Bowell's. There's no excuse like, oh, I don't have time, I can't get there. You guys can literally walk across the street and see me at lunch, or before class or after class. And so my patient, go ahead.
Is it a free clinic?
It's not a free clinic.
It's not for the students.
It's not. Is this school free? No, nothing's free.
For it,
Yeah, exactly. So usually if you're on your parents' insurance, most of the time you get 30 visits. I think with the student insurance you get 30 visits and there's like an 80-20. So the insurance pays 80, you pay 20% of the bill.
How much
No.
is it?
It depends on what I'm availing you and how long I see you for. So it really depends. Like I had a student that they were on their parents' insurance. It's not anything. She has no copay at all. So with the insurance that you get through CASE, it's a little bit more expensive. But say like the evaluation's $300, you pay 20% of that. I don't know if that's exactly it. But if that's what you're concerned about, a lot of times after this lecture, I give people my cards. We can kind of discuss what's going on. I can give you some exercises, see if that helps. But it's kind of hard to evaluate somebody without putting your hands on them, assessing their spine, all of that. But a lot of times there's things that I'm going to give you today that you guys can try that may fix your problems today. But yeah, I don't know exactly. I'm not the billing expert. But we'll talk about it. We'll go there. You guys will have my cards and my contact information, and I'll help you as much as I can in a free clinic kind of consultation way. But sometimes it's best if you come in and just get evaluated. And once I evaluate you, I can see you 1 to 2 times, and then get you in the gym and on your program, and then we just consult via email. So then it's more cost effective. Because I know going here and insurance and all of that is expensive. I get it. And that's it. I have my doctorate degree, so I got into a direct entry program for undergrad and then went all the way through and finished my doctorate. So most PTs have, if they graduated in the last 8 years, have their doctoral degree. Okay. Importance of ergonomics. Okay. So a lot of times the dentists that I talk to, especially like people that had gone to school before me or before you guys, hygienists, people that my dentist that I go to, I ask them like, did you learn about or did you get any adequate education about ergonomics in school? And most of them say no. So I think that like having some sort of idea about ergonomics and considering that when you're planning a clinic or just when you're setting yourself up in the clinic is really important. And this can lead to, if people have no idea about ergonomics, they just buy equipment that they think is the best, but that doesn't necessarily fit their clinicians or what they're comfortable with. I have some pictures of seats of my roommate in college. She's a dentist, she works in Boston, and she likes the saddle type seat, and that's her favorite thing. And Shelly said, I hate that type of seat. I do not want to sit on that type of seat. So everybody is different. Some people are taller will like certain chairs, some people are shorter will like different chairs, but it's really knowing how to adapt yourself to whatever chairs that you have available. I think that's the main thing, is we'll protect your spine and all of that. And you'll figure out what you like and what they're gonna have in most clinics. Okay. So if you don't know about ergonomics, it can lead to a costly investment in non-ergonomic dental equipment, poor positioning techniques that actually can worsen your health, resulting in chronic back pain, neck tension syndrome. That's kind of like the upper trap thing where people have so much tension and they have like knots in their upper trap, and sometimes that causes some radiating symptoms into their extremities or down their arm. Trapezius myalgia is kind of a similar thing. The tight neck, the upper trap that's really sending radiating symptoms. Rotator cuff impingement, pathology, functional weakness. A lot of times when we're in poor positions, it causes certain muscles to not turn on. And so when they're not turned on, then it puts more stress on the labrum or on the other more fragile structures of the shoulder or the neck, the disc, and all of that. So there's certain groups of exercises that are really important for you guys to do to protect and stabilize your neck, your shoulder, and the things that you'll be really using a lot when you're working. And then carpal tunnel, I'm sure you guys have learned about that. All right, this is the common work-related symptoms that dental students have complained to me or just in the literature. These are the most common things that are associated with just the job. Neck pain caused by awkward positioning to see in patients' mouths. Back pain, poor position or sitting posture, static positions, leaning, twisting for the oral cavity. Shoulder pain, maintaining the arms unsupported and away from the body. That's something that's like when you set your whole patient up and your area up, that if you set it up correctly, then you'll decrease the stress on your rotator cuff and your shoulder structures. Elbow, wrist, hand, repetitive, forceful movements, static grip pinch, all those things that you guys do. Headaches. Does anybody have headaches? No, not really. Okay, yeah. Sometimes those get worse when you're working with certain patient populations. And then numbness and tingling into your arms or hand. I think a lot of the patients that I see, they get really worried, oh, is there something neurologically wrong with me? And it's not. It's a posture correction. We get their spine moving better. We mobilize their spine and get them stronger, and that numbness and tingling goes away. And that's it. Why should dental professionals care about PT? Ergonomics, I'm sure you guys learned this, but I just like to review those. And applied science is concerned with designing and arranging things in people so people can work the most efficiently and comfortably. And ergonomics and physical therapy might positively impact dentists throughout their professional lifespan. More than 70% of dental professionals reported neck, shoulder, low back pain. So that's really high. And the people that I know that, my roommate, she doesn't have any neck pain, back pain. She's even pregnant. She's due soon, and she has had no neck pain, back pain, and practicing in the clinic. She does a lot of the things that I'm going to go over, and I think that's why she's really active, and she makes sure that she takes time to take care of herself, so that she doesn't have these symptoms. And then some of the other colleagues and people that I've worked with here, taught with, they do have back pain, and they continue to have back pain, and I've given them exercises, and they don't do them. So they'll continue to have back pain. So I think that's why it should be important. Reasons for early retirement for dentists, musculoskeletal disorders. That's all the things we talked about. That could be neck pain and the person has to get a fusion. That could be rotator cuff issues or a shoulder replacement or something like that. But the main thing is a musculoskeletal thing, disease or disorder, and that can be prevented with exercise, or at least pushed back out further. I've seen there's people who are young in their career and have to get a cervical fusion because they're having pain and they're dentists. If they would have done some of these things, I think that would be maybe have happened later on in their career, not so early on. Okay, awkward postures, excessive forces, high repetition, which you guys do all those, contact stress, poor condition. I think the poor physical condition is huge, and it's hard when you're a student and you don't have time to include some activity into your everyday life or go to the gym. But a lot of the stuff I'm giving you can do in a library or in your apartments. And just pick 1 or 2 exercises every day. If it's your neck that bothers you, there's a group of neck exercises. If it's your back, there's more back exercises that you can wake up and do some of those and then go into the clinic or come and study or whatever you're going to do. Okay, so principles for prevention of musculoskeletal disorders. Use tools to perform repetitive work, which I'm sure you guys are learning now. Like I said, making workstation layout changes to eliminate unnecessary upper extremity motions. performing active warm-up and stretching program. So that's before you see a patient or in between or at lunch, doing some of these like quick stretches. I'm sure you guys seen LeBron or baseball players, they're doing some of this active warm-up stuff. A lot of the pitchers do it. I don't know if you guys are Indians fans or wherever you're from, but if you like watch games, they do a lot of this like active range of motion things to get their rotator cuff really, really warm. So when they're throwing, it puts less stress on those structures and everything's warmed up. You guys can do the similar things. So I have another PowerPoint which you guys will be available to you, and you can put it on the back of your desktop and you can go and do any of those exercises at any time. Making sure your seats are properly set so that the edge doesn't compress the back of your knees. So some people think that you should sit all the way like on the edge of a chair so your knees are all the way up, but it's really not the best thing. So you want to sit so you have a little bit of room between the edge of the seat and your knees. Sitting, rotate the pelvis forward. We'll go over like putting the pelvis in a good position to take the stress off your low back. Are you guys familiar with like a posterior pelvic tilt or anterior pelvic tilt? Moving your pelvis to take the stress? No, okay, we'll go over that. Making sure that when you adjust the chair that the lower back, arch in your lower back is always present. If your back is flat, that puts more stress on the disc, so you want to have a little bit of an arch, but you don't have too much. You want to be in kind of a neutral spine, and that's where you have that nice lumbar curve. So we'll go over kind of creating that if you're on a chair that doesn't have a back or a chair that's not so great. So here's the two different types of chairs. And I think that like what you guys have in the clinic are just regular stools, am I correct? Just like the ones that don't have any back and they don't have any like slant or anything. So we'll talk about sitting in those chairs. But you really want to think about 90 degrees at the hip and knee. And sometimes when you have back pain or if you're having a bad day, if you get one of your textbooks and put it under your feet to kind of decompress your spine and get your knees a little bit above 90, that you'll feel a little bit better, especially if you're studying and you're in a chair and your back is bothering you. You get two textbooks, put them under your feet, and that will kind of decompress your spine and kind of give you a little bit more of a curve if you're struggling with sitting on that day. This is more of a waterfall type seat. I don't know if you guys have sat in any of these. Have you guys sat in a chair like that? No. Yeah. But sometimes people feel better. But I think it's usually taller people that feel better. And you're kind of standing up.
That's actually one of the chairs from the clinic.
This is one of the chairs from the clinic, so this is normal. Yeah. So when you're sitting, this is too tall for me. See how my feet are not flat. You want to be 90-90 and close to the edge. And what we'll talk about is positioning your pelvis so that you don't have too much of an arch, but then also that your back is not completely flat. And so we'll go over that and stand up and discuss kind of getting in that position when you're sitting. So this is kind of from one of Dr. Oceanero's lectures. So are you guys familiar with the different classes of motion? No, kind of. Yeah, so I'm not really that familiar because I'm not a dentist. But the main takeaway of this is that we want to stay away from the class 5, the major body movements. The closer you are to the patient, and the less movement you have to do, the less stress you're putting on your back, your shoulders, and all of that stuff. So class 1, you're just moving your fingers and you go down and you're doing major body movements. If you're setting up your patient correctly, if you're in a good situation with the patient, yourself, you're sitting in the chair correctly, you'll do more of the class 1, 2, 3, right? And then hopefully you're not doing as much of the class 5. Is that correct? Okay, good. All right, so this is similar to the chair that's sitting here, the assistant stool, but you guys are not the assistant. So I think that most of the chairs that I see in clinics are this height, but it should have a maximum height of 27 inches, be adjustable with foot pressure, and yeah, so you guys have seen this. So this is more of like if you're starting your own clinic and you're buying equipment, these are the things that you should look for, and then go from there. And then this is the saddle type seat that I was talking about, that my roommate from college, this is her favorite type of seat. But I think it's also like what type of patients you're working on. If you're in a pediatric setting, those kids are more wiggly, you're having to change your position more. So it really depends what type of setting you guys end up in and what type of body type and what's comfortable for you. Just because this works for your best friend in dental school does not mean it works for you. It's really being able to adjust yourself to whatever chairs and whatever clinic that you're in. Okay, so sitting in slouch position increases the pressure in your lumbar spine, can deform the nucleus pulposus slightly posteriorly at L5, L4, L5, and L5 and S1. And that's the most common areas where people have a disc protrusion, a disc herniation, and that's usually the areas that I have to treat or where people really have symptoms. So just changing your sitting position can decrease the stress on your discs, and that's important because over time that annulus fibrosis, that structure that keeps that disc together, it starts to weaken and reducing the ability to block that nucleus. I always explain to people the jelly donut. If you are always sitting forward, like this, the jelly of the donut is going to start to creep this way because your spine is pressing on the front of the donut and the jelly is going back that way. So if you can position yourself in good alignment where there's equal pressure on all the discs through the spine, then the jelly doesn't seep out the back. And that's usually common, either laterally or posteriorly is where the disc seems to start to break down or have issues. Now just because you have that doesn't mean you have pain. We can take 8 people, take x-rays, and some of us will have some sort of protrusion or disc, and only 2 people have pain, the rest of us will be fine. So those people probably have better stabilization of their spine, better movement of their spine segmentally, so they don't have pain. And that's why a lot of times people say, oh, I need to get an x-ray, I need to get an MRI of my neck, it's killing me, I'm a dental student, I need to get this. And it's really, that's not the most important thing. We need to get the stability of your spine. We need to get your spine moving, we need to get more strength, so those things don't get worse. MRI is not going to fix the problem. It's going to tell you what's going on, but that doesn't always tell you where the pain is coming from. Sitting with a flexed lumbar spine creates additional flexion of the thoracic and lower cervical region, and that makes you compensate. So if you're sitting forward and flex like this, then it causes, for you to be able to look forward, it causes the upper part of your body to extend, and it can put more stress on your TMJ too, because your cervical spine is compensating and then everything's not aligned. So if you don't start from the bottom, setting your pelvis up, it's going to cause this chain reaction of basically throwing everything off kilter and putting more stress on those structures that are really important. So that's why it's important that we do some of the stuff that I'll go over today. Back to forward head. So here are the main muscle groups of the neck that I work on. So the upper paraspinals, which is the semi-spinalis capitis and the later scapula, which comes kind of forward towards your neck. Those are the ones that, if I laid somebody down on this table and started palpating, and I'm sure you have patients like, oh, that's really tender. I'm really tender in my neck. My neck's really tight. That when you have this forward flex posture, you're working on patients, a lot of these get really stretched out and they get trigger points in them. Is everybody familiar with a trigger point? Some of you? Okay, so I'll go over it. So when muscles are stretched and they're not strong, your body compensates by tightening and protecting. And what it does is it creates these adhesions in the muscles that you can almost feel I'm sure you've felt it on people, that feels like there's a rock under there. So that's a trigger point, and that's an adhesion that your body's trying to protect you but it causes the muscle to go into a shortened, tightened, adaptively short position, and it doesn't work in its full range of motion, which throws off the other muscle groups that work together to stabilize your spine. So when you're in the stretched position, is a perfect prime place for trigger points to set up. And that's where I talked about the dry needling, where I find those rocks, I find those tight adhesions that can send pain to different parts of the body. Sometimes I could do it on my brother. He was a college football player. And I could hold on to this spot and bring him all the way down to the ground. And he was a big guy, but that trigger point literally sent pain all the way up into his head and all the way into his arm, and it brought him to the ground. So he had that trigger point. And so if I would have had needles then, I could have literally just taken the needle, you just do a little bit of pistoning around that area, and what it does is you kind of get a reflexive twitch in the muscle, and that trigger point releases. And then the muscle can go into the more of a relaxed position. Now, does it fix it the first time? No, it usually takes me like 2 or 3 treatments to make it completely go away, but it's something that can be really effective. Now, can I put needles in some of these structures where there's important arteries, nerves? No, I mostly just do it in the upper trap, and once you take the stress off the upper trap, it takes the stress off the levator, and then the semispinalis capitis. But I do put some needles up where the semispinalis capitis and the suboccipitals attach onto the skull, and do some periosteal pecking where that muscle innervates, and people get a lot of like analgesic effects where they feel like, whoa, I got kind of like this warm feeling and the muscles have relaxed. So I do some of that. So that's something that you could talk about doing as a quick treatment. So we just talked about prolonged extension, the suboccipital muscles, they become shortened over time. Increased muscular stress can cause localized painful muscle spasms called trigger points, which are often associated with headaches, radiating pain into your scalp. Like a lot of times when somebody says, yeah, I have headaches, people say I have migraines, so that's a different thing. But in the tension headache group, people can say, oh, I feel it here and then above my eye, and that's very tension headache. And so sometimes when I release some of those trigger points, I can do them also manually with my hands. You literally push on the trigger point for 30 seconds, you have the patient breathe. You can do that 3 to 4 times as tolerated, and that will help release the trigger point. But usually they come back, but at least they get a relief for those few hours once you release it manually. But a lot of times that this increased stress in the muscles and in the trigger points, they set off headaches. So I had a grandma that I was treating, and she said, I've had headaches for 3 years. Every day it comes on at 4 or 5 o'clock. And I did some trigger point release, and she didn't have headaches again. And she had been having headaches for years, and I could not believe that this poor granny had been having headaches, and all it was just trigger points in her upper trap and her suboccipitals. So that's just something that you could probably address yourself, or that I could help you address through manual techniques. Sometimes you can put 2 either lacrosse balls or tennis balls into a sock and place it over your suboccipitals and just hold that position and breathe. And you can do a good suboccipital release if that's the muscle that is bothering you or causing your headaches or causing some of your neck discomfort. And like I said, forward posture can be corrected through postural awareness, setup, therapeutic exercise, and manual techniques, which I just talked about. All right, so I like to present some research so we have an idea of like, is this something that's important or not, and is this something that we should value? And this study was done on orthopedic clinicians, surgeons, that low back pain is prevalent among clinicians, particularly surgeons, and they have the highest prevalence. And the risk factors were male, position, number of working hours per week, which is like you guys, depending, what your schedules can be now when you're studying and working in the clinic are high. Bending at work, pulling objects during work, and those are things that are significantly associated with low back pain. So these are all things that you guys do. Long hours, studying, and so we don't want low back pain if we can prevent it, and do some things to kind of prevent it, then you guys will be better off. This is an interesting thing, especially because we got the question about like, how much is this gonna cost? Because that's what everybody says. But then they go to their primary care after they've not seen me for months and months and months. Then they get an MRI, then they see this, and they end up in PT after they've had surgery, or they've had some sort of shot or whatever, and they've spent this much money. So usually that can save you money by just spending the money up front. To do a few sessions can save you a bunch of money, because MRIs and x-rays and all that stuff, if you haven't met your deductible, I don't know about the insurance that way. I just know what PT's covered. That if you can get in and work on the stuff, that you save money in the long run.
There's a saying for that.
What's the saying?
An ounce of prevention is worth a pound of cure.
Yes, that's great. Okay. So here's another research study that they had. They had two groups of surgeons, laparoscopic surgeons, which is, I feel like it's similar to what the movements that you guys do. It's like in a small area, they're not moving as much, they're using tools. But there's a group that did a warm-up, an active warm-up, kind of similar to what we're gonna go over, and then a group that didn't. And the surgical times were less, and than the group that did not do a dynamic warm-up. So if you wanna be efficient in the clinic, those people also reported less pain and increased blood flow to the extremities, even after hours of surgery. So I'm trying to get you guys to buy into doing something before you're treating patients all day. All right, let's do some active warm-up. Let me just make sure that I've gone over this. So we talked about all these things. Working on good postures, avoid static, awkward postures. Chair stretches, I'm going to give you handouts for that. And then we'll go from there. Yeah, we talked about that. Like I said, making an appointment with your physical therapist to prevent onset of musculoskeletal disorders down the road. There's certain groups of exercises which we'll go over. There's deep neck flexor strengthening. Has anybody done deep neck flexor strengthening ever? No, you haven't. So this is probably one of the main exercises I give patients with neck pain. These muscles are extremely, extremely weak, and they're what keeps your head up, and you use them a lot. So if they're not functioning correctly, they don't have good endurance, that your cervical spine is not going to be stabilized. So that's one of the most important exercises, so I'm going to give you that. A foam roll program. Has anybody used a foam roll? Do you guys mostly use it on your lower extremities, or are you using it on your spine too? Lower extremities. Okay. So I'm going to give you some general spine mobilization things. A lot of times, like people, like they'll roll out their hamstrings, they'll roll out their quads, which those are good. But some of these are more, we need to have good spine mobility when we're working with patients. So that's, I'll give you a handout for that. I do spinal mobilizations on the cervical and thoracic spine. That's what I'm mostly working on with people with neck pain, cervical or postural dysfunction, grade 2 to 4. So grade 5 is like a manipulation that like a chiropractor would do, which we do some, but it's not really in my, unless it's very acute. Like if you were with a patient and then all of a sudden you couldn't move and you were in a lot of pain, then I could manipulate you. But if a lot of the patients that I've seen here, they're like concerned about costs, they're like, oh, it'll be fine, and they go months and months and it becomes a chronic thing. So manipulation's really not, for me, that's not the first thing that I go to. I just do gentle. 1 to 2 is more of like for pain management, and then 2 to 4 is more of like mobilizing your spine. And there's usually people have areas that are really painful and hypomobile, and I focus on that area, and then I have them move again to assess to see if we have more range of motion once we get going. And then scapular stabilization, that's just making sure that not only the rotator cuff is tight, is strong, But also working on the muscles that are tight and your pecs are tight. A lot of times when we're in bent over position, the pecs get tight, but then working on your muscles in your back of your shoulder, so your upper trap, lower trap, rhomboids, all of those muscles, making sure that those are really strong too, so you take some stress off of the rotator cuff. All right, so foam rollers. So here are some of my favorite ones that are good for posture. Think about it, if we are forward flexed all day, getting into the extension position and getting in the opposite direction that you're in all day is going to help make sure that you have the range of motion in that opposite direction. If we're in flex position, we want some more extension. Also, you can use it, just on the area that feels sore, or where you feel like there's trigger points or tender points, and just hold it there and breathe, like I talked about, doing some sort of release. And then here's like rolling out some of those muscles, the rhomboids, the trapezius. Okay. Has anybody seen a Theracane before? No? You've seen one before? Yeah. So this is a good way too, if you don't have somebody who can work on you and work on those trigger points in your upper trap. There's this tool you can order on Amazon, and that you can use it to work on those really tight points in your back and your upper trap. This is something that most dental clinics should have, because the secretaries will use it, the dentists will use it, everybody uses it because they have areas where they have the trigger points. And basically what you would do is you apply the pressure for 30 seconds, 3 to 4 times, to release the adhesions and increase the blood flow in that area. Chin tuck, so this is the most important exercise for neck pain. So if somebody has neck pain and they don't want to pay whatever you have to pay to come over to UH to see me, this is the exercise you're going to start out with. And this is working the deep neck flexor muscles. So all you're doing is you're doing basically a retraction of your spine. And I always like to tell people, have you ever been somewhere where somebody's gonna kiss you and you don't want them to? Your grandma, or at a bar somewhere. This is like, don't kiss me. Retract your neck and push into the pillow, and you'll be good to go. Okay, so just being in school and in general, I think that a lot of times, I think you guys probably have learned too that there's people who are more nose breathers compared to diaphragmatic breathers. And if you're not breathing correctly, your spine is not being stabilized correctly, because it's basically a whole tension of muscles working, breathing, all that together. Like a lot of times when people are lifting weights or they're working on patients or whatever, they hold their breath. And this is also good for like managing stress. You should be able to diaphragmatic breathe. A lot of times if you're using some of the supplementary muscles to breathe instead of your diaphragm, that your neck's going to be tighter. So if you're having any type of neck pain, you need to work on making sure that you're correctly diaphragmatic breathing. It's something that everyone should do, especially in the morning if they're just waking up or they have some neck pain. Do some diaphragmatic breathing. Upper trap stretch, this is important. Most people have tight upper traps. I like more of an active stretch, and the research shows that doing more of an active upper trap stretch gives you better blood flow, there's better performance, especially with athletes. But sometimes you're studying and you don't have time to do it, but after you've been moving around, you've been working with patients, static stretches are okay. So this is probably one of the most important ones. Levator scapula stretch, this one too, people feel a lot of tightness. I call this the armpit sniff. And you can do that and get a good stretch in there. But these are all exercises I give to somebody that has neck pain. Doorway stretch, you guys can do this in the clinic, you can do this in the library. Opening up your pecs, making sure that your anterior muscles, those muscles that are in shortened positions when you're bent over, you're hunched over, you're flexed, really flexed, are also stretched, are really important for keeping your spine aligned and keeping the stresses off your neck and your shoulders down. This is probably the best exercise that you can do in any classes if you're feeling some discomfort in your shoulders or your neck. So what I want you guys to do is you're going to pull your shoulder blades down and back. I don't want you to pull your shoulder blades up towards your ears. I want you to sit up straight, and I want you to think about tucking the back of your scapula down into your back pockets. And what you're gonna do is you're gonna hold that for a few seconds and then relax. So when you start to get bored, or like people start to close their eyes and you're like, this is really boring, she's boring, there's a lecture, this is something that you should work on, because these muscles are really important for pulling your chest up and kind of resetting your spine. Shoulder rolls, you guys, I'm sure you've done that. That's good for neck tightness, shoulder tightness. You can do that in class. These are things that you just think about that you can do while you're sitting here. The most painful muscle and the muscle that's most affected with me, with rotator cuff injuries, has anybody had a shoulder or rotator cuff injury? Yeah. So a lot of times when the neck muscles are weak, the rotator cuff is weak, that people have the most pain in external rotation, and those muscles are the weakest. And that's usually why they have this injury that they have, because this muscle group of their rotator cuff is really weak. So what I like to tell people is that this is probably the most important exercise you can do. And you're gonna really squeeze your shoulder blades back too and kind of incorporate the other exercise we did as we work on strengthening the rotator cuff. Now if you don't have a band like this, you can literally use a cable cord at the gym with like 5 pounds and keep your elbow really tight in and open up. But we can talk about that if you don't have a band. But most of the time, there are bands at the gym that you can use for this exercise. This one's good too. This works your lower trap, some of the periscapular muscles that will help kind of stabilize your spine. Rows, you guys, everybody's probably seen these before. Also, postural muscles that need to be strengthened. This too, press-ups. This is more extension. So if you're flexed a lot, you're having a lot of pain, this is something in the morning that you can do a few of these, or at the end of the day, to kind of reset your spine and get some more range of motion to extension. Serratus, one of the most important stabilizers for the rotator cuff and the scapula is the serratus anterior. That's why we see like boxers who like punch at high velocities. They have these like fishy-like muscles on the side that most normal people do not have. That is the serratus anterior, and that's why the shoulder doesn't get blown out the back when they punch people at high velocity. So it's a really important muscle for stabilizing the rotator cuff and shoulder, and most people are not doing this exercise in the gym. Boxers do variations of it that we normal people can't do, but I never see anybody doing this in the gym ever. So this is something that you pick maybe a 3 to 5 pound weight, and what you're doing is you're kind of pushing up towards the ceiling and then coming back and squeezing your shoulder blade down and back like we did with the other exercise. But that's a really important shoulder exercise that you guys can add. Planks are really important for stabilizing the core, and those are some of those exercises. All right, so I talked about earlier that there are physical therapists that can treat TMD, and they help restore the natural movement. I'm sure you guys have talked about like the people that can't open their mouth all the way, or the people that can't that are stuck open and they can't completely close because of the disc issue. So what we use is we use posture education. A lot of those patients that present like that, they have really weak deep cervical neck flexors. They have really weak periscapular muscles. So when we assess their posture, we also work on those muscles. I talked about using ultrasound to decrease the inflammation there. But we talked about how if your posture, think about it, if everybody get in their terrible like forward head posture, that causes your chin and your mouth to open and puts a lot of stress on the back of the disc. So just correcting some of that with people that are having issues can change a lot. We improve the jaw movement by what we do is we'll take a glove, obviously, you guys wear gloves too, and mobilize the jaw superiorly and inferiorly and forward and back, if that's what they need, to stretch the jaw if they're having trouble opening it. Or we can do some soft tissue and breaking up adhesions. There are people who are certified in doing dry needling in the pterygoids and some of the muscles that stabilize the jaw. I don't do that. I don't think I'll ever do that, because I don't really treat the TMJ. But like specialized clinics like the one in Beechwood, they do some of that too, to release some of the trigger points in those muscles, or those muscles that have gone into a spasm, and that's why the patient can't close or open their mouth. We teach them low load exercises that don't exert a lot of pressure on the TMJ, but strengthen the muscles of the jaw to restore a more natural pain-free motion. Usually a lot of the times what we see in the clinic is that there's a muscular imbalance. So whether it's at the neck or the shoulder or the TMJ, that certain muscles are really strong and doing more of the work, and the other ones have gone on vacation and they're overstretched perhaps, and they're not doing their job. So there's special treatments that we can use, like electrical stimulation and ultrasound to reduce the severe pain if they can't tolerate some of the stuff that we do. And then if it's caused by teeth alignment, usually you guys are in the picture. You've started the process where you've made them a mouth guard, or you've given them some things to work on, and then you're sending them to us to work on more of the posture education and working on the movement mobilization and getting some manual therapy and maybe some, the ultrasound and all those kinds of things, the e-stim, to decrease the pain. It's also education that we give the patients about eating certain things. I'm sure you guys talked about like chewing gum, crunchy foods, all of those things. We also take the time to educate patients on those habits. Do you rest your head on your hand? Do you chew on your pen? All those things that can trigger the pain in the TMJ. It's mostly just education and activity modifications that are the most successful outcomes. And that's kind of like why I'm here today, is that like I'm giving you guys the education and the tools so that if you can just change your activity a little bit and modify so you don't have pain, and then we get a successful outcome. Stress, that's why I talked about breathing. This is probably one of the most important categories for back pain, neck pain, TMJ pain. Depression, anxiety, and stress are the known cause to contribute to bruxism, grinding of your teeth. Does anybody know if they do any grinding or they have to wear? Yeah, so a lot of people have this. I think that I have this too. My husband says that I have this, but I can hear him grinding and he has some issues with it. But they enhance the sensitivity of the jaw and the surrounding structures. So like even just if they come to me first, I'm treating that, making sure that they come back to you guys so that they have a mouth guard. And so when they are grinding, that's taking off the stress of the tissues. Is your pain worse around big tests or deadlines? Well, my pain always was. So I'm sure you guys understand that like relaxation and stress management, school's very stressful, that like understanding that can contribute to your symptoms. Sleeping, are you sleeping enough? And does your jaw feel better or worse in the morning? That's the same thing goes for, does your back feel better or worse in the morning? A lot of times people say they feel better in the morning, and then as they go throughout the day, their back feels worse. Or their jaw feels worse in the morning and as they go. So I ask those questions to those patients, but it's kind of good for you guys to know what kind of questions I'm asking and what you can ask patients if you have the time to see if they're appropriate to send to me or to a physical therapist that sees this type of patient. Okay, this is my roommate in college, and so she says that she works with a personal trainer 3 days a week. I can't personally afford that, to ensure that her core supporting muscles are strong. She gets massages every couple of weeks, and when she's in trouble, she contacts her physical therapist to get things back on track. And her thing that she always says, as a dentist, your back and neck take a beating, you have to stay ahead of the game. So I'm gonna give you guys some things today so you can stay ahead of the game. How is the dentist, David? Fine. Good. So let's go over, let's escape this. We'll go over some of the things that I opened before. Let's do this one. Okay, let's have everybody stand up. Does anybody have any questions about what I talked about before? Or questions about? No? Okay. Let's stand up.
My favorite stretch?
Okay, so these are some of the dynamic stretches. I'm giving you a ton of them, but you can have like 2 or 3 favorites that you do that you step out or you do before you see a patient, or things that you do in the library when you're like, okay, I need to set up, I'm reading the same sentence over and over, I need to take a break. So here's a saw. So you can change your hand position to supinated position, neutral, pronated position to change the muscles that are activated. So let's start in the supinated position, and you're gonna just go all the way up and then all the way back, squeeze your shoulder blades. We'll do about 5 or 10 of them, all the way back. Okay, let's change our hands to neutral. And you'll feel different muscle groups working. And then hands down, pronated position. We feel muscles, because my muscles are burning. Okay. So just getting things moving. That's what it's Scarecrows. So you're going to start the goalpost, you're going to go up, turn your hands in, turn your hands out. I feel this in my rotator cuff. I feel it, and then you go back down. I feel the burn, but maybe it's because I'm pregnant and out of shape. But I don't know. I feel it. This is probably the one that I use the most when I'm sitting at my desk and I feel like I've been writing a lot of paperwork, I've been working on patients, I feel like my pecs are tight, I feel like I've been hunched over, just opening up, squeezing your shoulder blades together, opening up like that.
Make sure you get this on good publicity.
Still running. Go all the way up, and the hands in, and out, and then down. And then this one, the airplanes, you're going to all the way out, hand and all the way
Why is everything so loud?
And then wave the hands all the way up, chest out, yep. Open up your chest. And then reaching all
Before I
the
do
way
any
up.
procedure, I'm back. Let me get in here.
Look your patients in the face.
Yeah. Are we gonna do this together?
And then this is really, this is probably my favorite one for your upper trap. It's more of an active one if you can do it. So what you're going to do is you're going to extend your side bend away from the side you're pushing. So you're applying, a stretch on the origin and insertion, and then you're going to come back, release it, and then you're going to go down, and then back up. Down. So these are all things that you guys can do anywhere on campus. And this is a good one. This stretches the front. Scalenes. All the way up, you're going to look up, push down, stretch the front of your neck muscles that we never stretch. Unless you're in yoga, you can probably stretch these. And then some of these are just like lower extremity stuff. If you're having back pain, I can't do this right now, so somebody has to demonstrate. You're just going to pull your knee all the way up toward your chest, and then kind of march in place, pull your other knee up. So these are good like pre-running things, like if you run outside, you can do some of these hamstring stretch active. You guys can't do that, you're going to kick somebody in front of you. hamstring, and then you do this one where you're just scooping up, like you're scooping up a ball. If your hamstring's really tight, you're having some radiating slowly to your back, sitting forward.
We used to do crab. We used to do crab walks and scissors, making those parts that stretch. Really gets the body
Hamstring
moving.
and glute exercise. I won't make you do it. IT band stretch. Some people are runners. They have some IT band issues. This is a good one. And this is a good one. This is my favorite one. If you're having some pain at your buttock, if you've been sitting for a long time, your butt gets numb, you've been studying for 8 hours, you cross your leg over and sit back in a chair, and you'll get a nice glute stretch that you can do after you've been sitting. So I would save this PDF to the back of your computer. You guys have your computers all the time, so you can kind of refer to this, and then you'll know what's on it and what you need to look at. And then I also
Pop right into 4 or 5.
so that's great. That's all you need.
Straight into it.
There's another handout. There's a phone roll, there's a form roll, and they're all in Canvas. Okay. So you guys have those.
Thank you.
You're welcome.
Oh, I see what you're doing. There are contraindications to the supine position. You know, I said in my blog, I said there's an adage that we use in regards to a variety of parameters that we lay on chairs and equipment and supplies. Plan for the usual, not the unusual. Well, the contraindication is one brought up, is breathing difficulties, congestive heart failure. Can't put a person in a supine position, they have congestive heart failure. Now, we used to put that out on the chart. Now you don't, on the front of the envelope of the chart. Now we don't do that. Computers are supposed to make things better. They don't. Now, in the case of charting, I don't think they do. Because there are certain standard things that you have to write. I have a son that's a pediatrician on the west side, and he had a physician's assistant come in, and instead of him inputting on the chart, he signed off on the chart. He would dictate to, I think it was a her in this case, that what he had done for the child, because it loses something in translation, and what he had recommended to the patient. So they're actually looking into the disparity of automated verbiage versus dictated verbiage. So, laying the patient back in a supine position, 3rd trimester of pregnancy, can't put them back. Breathing difficulties, severe sinusitis, okay, congestive heart failure, or I can't go back, I get dizzy. So again, plan for the usual, not the unusual. In a general practice office, you just accommodate. What are you going to do? You're going to stand up. It won't, it won't kill you. That's not the norm of your practice. Well, it may not be the norm. It may be your norm, depending on what you want to do. But you're trying to accommodate the patient. It's all about the patient. I don't know if you ever saw the book, The Purpose-Driven Life. It was written by a gentleman who was studying to be a priest. And he decided he didn't want to be a priest and so forth. So, but he wrote this book called The Purpose-Driven Life. And actually it's online, and I'm sorry I can't remember his name. But the first thing he said in the Purpose-Driven Life was, it's not about you. Once you get past that, when you're in dental office, it's not about you. I mean, you'll effectively benefit, but it's not about you. It's about that person in the chair. Yeah. And so, all this business about tension, I believe it. I mean, I've sat in the chair and with patients and been on the edge. And, you know, I talk about positive back support. And all of a sudden I realized my shoulders were like this, you know. The shoulder muscles, the traps were so tight. And you just had to sit back and let them relax. Because you're so concerned and consumed about what you're doing. You know, we're working pretty close to the brain there, you know. So you're concerned about how things are coming out and so on and so forth. Whatever it may be, the simplest preparation, whatever it may be. What else? As a right-handed individual, I'm a little confused about direct and indirect vision. Ordinarily, I assumed indirect vision would be used for all maxillary treatment. True, that's true. However, I heard that some can be seen directly. What teeth are viewed with indirect vision? Well, it is usually the maxillary teeth. If you look at the diagram the diagrams that I put and just looked in the area of visibility, you will see that the majority of comments are direct vision. I mean, that's why you put the patient in the supine position. Most of it is direct vision. Mandibular arch, you can do by direct vision. Do I use a mirror? Sure, I use a mirror. If I'm scaling the lower anterior teeth on the lingual, I use a mirror for reflectance. Of course, you have a headlight that takes that away. But in my day, we used a mirror we didn't have headlights. So, the upper arch, I use indirect vision a lot. I like indirect vision. And once you get the hang of it, it's a piece of cake. You'll love it. You know, you can retract with one finger, hold a mirror, almost in the same hand, and do your cavity preparation. Now some of the features, I don't know if I can do this right, Shelley. I got it. So I know I should put the gloves on. They're here. I'm gonna wear the gloves. And I don't mean to make light of that. But you know, all preparations on the buccal of these teeth, or even crown preparations, can be started here. Now this head is not in the full supine position. And you'll see from the diagrams that I've included on this last segment of positioning, that the upper teeth should be parallel with the front of your body. So this should go back further. I don't know if it does or not. The lower teeth are always, I use the comment, parallel to the floor. Parallel to the floor. You can look, you know, directly on them. Of course, there's no cheek here, but I can see back to the second molar. So, okay. So just look, when you look at that diagram, what are the things that pop out to you? Well, there's certainly a heck of a lot more direct than there are indirect. Can a wrist hand disorder such as carpal syndrome be career-ending for a dentist? Is the discomfort reversible with proper modification? Well, if it's not corrected, it's career-ending, because the pain is so excruciating. And it usually happens to people using things like ultrasonics, where there's a lot of pinching and, hand scaling, and periodontists who do scaling and replaning, that pinching motion and the vibratory motion of ultrasonics. And I don't know of the incidence, if it's gotten less with the sophistication of instrumentation. I haven't seen it. Hand splints are available. They're usually plastic hand splints. They really get in the way of the operator. And so eventually surgery is done. That ligament that goes over the medial nerve is released. And they have different ways of doing it. They can do it robotically now. They just go in and make a slit in here, and they put in balloons to sort of elevate the ligament. And then they put in a surgical tool that goes in, and they draw it out and release the ligament. And it's successful. How to make a patient comfortable while being at the optimal position? This is a good question, because remember I said, it's not about you, it's about that guy there. One thing to do is advise them why it's best. Well, this was, I thought of when this question came out. Oh, wait, Doc, why are you putting me back? Because you may get that. And when we first started with four-handed dentistry, we got that. Why are you putting me back? Well, don't say, so I can see better, or always relate the benefit to the patient. It expedites the procedure for you, Mrs. Smith. And don't lay it on yourselves. Tell them why it's better for them. We can evacuate the fluids better, whatever. Also, for patients, and Brianna brought it up, patients have neck pain. And sometimes the pillow headrest doesn't help. And even though it's not very restrictive, certainly not as restrictive as the cup headrest, it still is confining. So we used to have, I think I had about 6 or 8 of those silk pillows. They were silk pillows. And you'd have to take care of the outside covering, because you wouldn't want to transmit something like skin disease. And we put it on the neck. We also had a pillow for the back. Patients have back pain. It wasn't the usual situation, but as patients age, they get different aches and pains. And sometimes, as I've written up there, we give them Tylenol or a muscle relaxant. Very rarely a muscle relaxant. I mean, if it was something that we knew about ahead of time, we might pre-med with a muscle relaxant. But Tylenol takes the edge off of it. So I wanted to touch on those. Look at the other questions, some very good questions. And incorporate that stuff. Now, where am I? So, I wanted to show you this. I don't think I did this. This was the 3rd year class at the end of the year. It's interesting. We're going to see where you guys are at. Okay. hand pain. Question was, where was the pain? Shoulder, neck, head, upper back, lower back. So, what time do you stand, how much time do you spend standing doing? 11%. Majority of folks sit down. I was happy to see that. That's a good place to be. So that was interesting. But, you know, this is the end of 1 year in the clinic. So just to go over this again. Some of the numbers may use different distances. This says what, 12 to 16, the focal distance. The minimum should be about 14. Look at the head, it's just slightly bent, 5 to 10 degrees. I'd love to take pictures of you guys in the clinic. I was allowed to do that in other days. Some of them, and I know these guys as dentists, some of them I hired as preceptors. They should have been a basket case. So the back fairly straight, positive back support. There's some negative feeling that positive back support isn't good. I think it's good. I really think it's good. When you get out on the edge, you start developing tension. Look at the arms, perpendicular, horizontal, patient in the mid-sagittal plane. These are not parallel to the floor, and I don't know if this individual is straddling or not. One concern that Brianna brought up was Shelley's dislike of the saddle seat. There are a lot of people that don't like the saddle seat. And you gotta watch that this thing doesn't get here, because your foot will go down. That'll drive you nuts. You know, you sit, if the chair has a deep saddle. And this is 18 to 25. I'm using 21 for the operator. This should be down more. Feet flat on the floor. And people say, well, can I put them on the ring? Yeah, you can put it on the ring if you want to. And the bending should take, this is where the bending should take place. I failed to mention that before. At the hip, not at the thoracic or lumbar vertebra. Because we know what that does. Okay? So, we talked enough about this, I think. That's how you adjust. Those are the criteria. Port 1, patient shares position so that the mount as near as possible to the operator's elbow height. So if you're lifting your elbows, that's not good. You're either sitting wrong or standing wrong. Distance from the operator's eyes and the patient out, no less than 14 inches. We have to use one standard, especially if you're testing people. You know, it could be 15 plus or minus a couple. You've got to have things in focus. Elbows, side of the body, shoulders are parallel to the floor, back is relatively straight. The neck is not bent excessively. I did get a kick out of one question. Someone asked, well, how do we know we're sitting the right way? You know, unless you have someone there watching. In the old days when we had an auxiliary force of about 20 assistants, and they were trained to evaluate the posture of the operator. Now, this is an industrial diagram. That's why these arms are so high. And it may have been overkill, but you're right, there's no one that sees you outside of the person you're operating with, or someone crazy like myself taking pictures. I won't take pictures. I don't want to worry about a legal release or something like that. Probably could get by it through IRBs. So, you know, this is the supine position, sort of exaggerated, of course. Upper teeth sort of parallel with the body. The occlusal surfaces of the mandibular teeth are parallel with the floor. You have direct vision right down on it. Well, the question is, because you don't have a chair like that could probably go straight out like this, well, how the hell did I do that? Well, there used, in some headrests, when you buy a chair, the headrest, just the headrest, this part up here, articulates. In other words, it's still straight here, but it's got a button you can raise the headrest. And that will put the teeth, the occlusal surfaces of the mandibular teeth parallel to the floor, where you could look right down on them with direct vision. Otherwise, if they're back like this, you may have to use a mirror indirectly. So, but you don't have an articulating headrest. I don't know if you've noticed. You have a pillow back headrest. One thing you can do if you don't have another silk pillow is invert that pillow back headrest. Turn it upside down. And then, then lower the chair and raise the back slightly. The goal would be, I'm working on the mandibular teeth today. I'm going to get the occlusal surfaces parallel to the floor. Anything that improves this configuration, you know, burn it into your mind. Or you have a colleague, it's one nice thing about the preceptor group, have a colleague, hey, tell me if I'm looking goofy while I'm sitting here, or tap me on the shoulder, because you get so consumed about what you're doing, you forget you're trying to get the job done for the patient. Oh, here's a position. Some people complain about what we're going to see upstairs. You know, someone said, I can't get the patient in the right position, I'm too tall. I think it's him. So, also the business about the finger rest. We make a big thing about that with the EFTAs because they're using hand pieces. When I first tried to get that through the state, I had a lot of pushback by dentists. Oh, you mean they're going to use a handpiece? Well, it's only a tool. I mean, it I guess could be a lethal weapon, but we haven't killed anybody. So again, the one before that, I wanted to emphasize, this is where the assistant's tray is, this is where the doctor's tray is. You know that the tray headrest can come over to the side, and you could put it very close to your right hand. The assistant shouldn't necessarily work off the tray over the patient. And that may be true with the sealant program. The question came up, well, where do I put my instruments? Now, I haven't seen the newer chairs, but I don't think you can get the Mayo stand underneath the chair. So you almost have to use it behind. In the absolute wrong position, because 11 to 2 o'clock is a static position. But, you know, you have to accommodate. That's not the usual situation. So here's another individual attempting to do it, and I can see this is EFTA, and he looks like he's straddling that. Oh, not the best posture. And this is much more serious in the neck. You know, her head is almost perpendicular to her shoulders. So, and her arms are up, and she's straddling. Not a good deal. Not a good deal. So this is the chart that some of you had asked me to put in, and I did as directed. Lower anteriors. Actually, you could do this, I mentioned the other day, direct labial if you're scaling what I call the 8 o'clock position, where you're scaling the anterior teeth. Maybe you can get the other ones.
Do what?
The other chair. Put it on the assistant side. This points up the fact that a wide back chair does not work. Had we put this on the edge, it would more simulate a thin back chair. Go ahead. I don't know. Maybe turn it around a little bit. Because those get- Well, because you're in their way. To move over this way. So, well, of course, here I can get my thighs underneath. So, with scaling, this can be all done by direct vision. And if you want to scale, and actually direct vision by the anterior teeth as well. No problem. And just about all the posterior, this is not, well, down here would be probably a little bit more where the occlusal surfaces are parallel to the floor. But, you know, with a real ivy, and you can see this may be bent up a little. That's what the headrest does. Will that loosen that? So that gets the, and then this should all go down. You know, because now it's too high up. So I think probably the best thing would be if they put a full-length mirror at the end of the operatory. You could see how you're doing. So, lower anteriors, backrest, horizontal, direct vision, straight or turned slightly towards the operator or the assistant. The operator is aspirating. I mean, if we're using ultrasonics, that's a good thing to practice with aspiration and retraction. To rotate the patient's head to the right. Like so. Saliva ejector here, aspirator here, usually. We'll talk about this. The assistant holds the high volume aspirator, thumb to nose grasp, or they could use pen grasp too. That's more of that pinching stuff, pen grass. Oh, should know the different grasps. One is pen grass. Show me how you shouldn't do it. The pen grass. Remember the pen grass you showed me yesterday?
This. Well, that's next week.
Huh?
I'll be able to show them on the camera.
No,
next
no,
week.
I mean how not to do it. Where some students grasp it in here like this. Like that.
For suction.
Oh, for such. So, at any rate, pen grasp. Retraction operator, lower lip with thumb and index finger. So there's no shroud in here, but usually anytime you retract, except in a couple of incidents, do it with your finger. Do it with your thumb. If you're working on the upper arch, I've done it this way, held the mirror this way, and retracted at the same time. And then the handpiece, use the finger rest. Just for more stability, and the preparation comes out better too. Finger rest, okay, lower anterior. So lower anteriors, we just talked about that, direct or indirect, we don't have to go over it again. Chair, seat lowered maximally, chair back, elevated if we're getting the occlusal surfaces parallel to the floor. Straight or turn slightly toward the operator or the assistant, depending on which arch you're working in. Operator retracts the tongue with the back of the mirror. So, if I'm doing here, I would retract the tongue with the mirror. It's the only time that you should retract the tongue with an instrument, with a mirror. There is another instrument, I told you, it's a Swedish instrument. It's pretty nifty. It connects to the HVE, high volume evacuation. HVE. And that's the thing that's called a spedopter. It's great when you're doing crown and bridge procedures, because you hook it up to the HVE, put it in the mouth. It's doing high volume suction, like everything in the system. And it's on the lingual. And you can use your high-speed handpiece, not even worry about the tongue. Now, some people have tried to use cotton roll holders. The bad news is with that, they get soggy and messed up. And if you get them in the burr, you gotta propel it, okay? Because it'll go around. You should drag it off one of the points, you know, one of the points of the, what do you call it? No. One of the points of the cheek retractors, because it has those 2 points. So look these over. You know, the things that stand out to me are, well, what really has direct and what has indirect? And then I'll deal with that. What is noticeable about the retraction? Well, it's noticeable, if you read through this, that the operator does the retraction. The auxiliary does the aspiration. Lower right posteriors, direct. 10, 9, 11. Seated, lower back rest slightly elevated. We're talking about the lower right posteriors. In our case, in your case, when you're in the clinic, to get those posteriors, the occlusal surfaces parallel to the floor, you've got to elevate the chair, you've got to elevate the backrest of the patient, so the occlusal surfaces are parallel to the floor, and then lower the whole chair base on your lap. Okay, patient's head position. Turn slightly toward the same reason. Turn towards the operator maximally. Chin elevated slightly. Well, the chin is elevated, so for visibility. You know, if you're sitting there and it's, oh my God, I'm getting pain in my left shoulder. Well, answer the pain. You know, what are you doing? Or say, you know, Jake, what am I doing wrong? And you may be slouched over it this way. You're not maintaining your posture or your back support. The back support is a good guide for me. I have used for a few years. So, lower left posteriors. Somewhat similar. So we're going, when we get upstairs, we're going to go over a couple of these areas. Make sure you read them over. I wouldn't memorize them, you know, it's just what's practical. If you're having problem, especially with indirect vision. I don't know how we went through that so fast. Oh, the upper left. So here we go. Direct, direct, direct. Indirect, occlusal. Notice he's over at 11 o'clock. That's where I am here. Occasionally I'd work at 9 o'clock on the lower anterior. Well, it's more 10, 11 o'clock. If I was dealing with parallelism, I'd be almost back here. And we'd use a, say we're the teeth on either side, and we're going to take a full arch impression. I'd use what's called a rhodium plated mirror and put it in over the occlusals, and I could see every line angle of every tooth to make sure the case was parallel. We did a lot more of that things when we were doing castings. And it's unfortunate that gold's got so expensive that we're not doing it anymore. But if you're doing a bunch of PFMs, look at the retraction, index finger, left index finger. Now here's the only one where the assistant retracts with the index finger. I think that should be changed because I'm looking on the upper left. You can retract with your index finger and still use the mirror. Still use it. Why don't you want the assistant to retract? Especially the tongue. Because as you develop your skill sets, you can anticipate whether the patient is going to choke or not. And usually the sequence of instrumentation, when you go into the mouth, the doctor goes in with the handpiece and the mirror first. Then the assistant comes in with the aspirator tip. Why? The patient, if the assistant goes first, then the doctor has to get out of the mouth, and then the aspirator tip. If the patient starts choking, the aspirator tip comes out, and then you're in control. Okay? So it's a matter of safety. Right?
Yes.
Good. Okay. All the finger rests. Many times I will use, I brought this up with a junior student. One of my pet peeves is patients coming in and they have incisal lesions. You can actually see them. There's a dip in the enamel at the incisal edge because of wear, of attrition. And the student does comprehensive care. They turn in the case, and there are all these anterior divots. A hole, by definition, is a cavity. You know, so if you're not gonna put crowns on those teeth or veneers, well, you should be filling those teeth with composite. You know, and I portrayed that to patients in the office when I had the consultation. Filling those areas is preventive in nature. I've seen teeth worn down almost to the gum line because patients were eating like a bunny. They had no posterior teeth, and so all the incision and even chewing goes on in the upper 6 or 8. So what's going to happen? What's going to wear? And so we know what a tooth looks like. The outside matrix is organic, it's enamel. The inside matrix is organic. So it wears down. You've got these spicules of enamel up in the air. The patient chews, they break off. They continue to chew. Another divot starts in the organic matrix, bringing up more spicules. They go off. And the teeth get progressively shorter. We don't do anything about it. Well, we do. So, and those lesions, when they're small, they're easy to fill. Sometimes they'll fill them with sealants. You know, I tend to fill them and then wrap them around the incisal or lingual, so it's much more aesthetic. I think if you just fill them up like a bathtub, I should have brought some pictures in. Fill it up like a bathtub, it will still wear. It will still wear. Not as fast as without anything, but it will still wear. So, well, you can read the rest of these. There's some sameness, lower posteriors, all direct, 10, 11. It's all about the posture, really. We talked about this time. Talked about that. Some exercises, some pictures. I'm sure Brianna has some demonstrated finger rests. Okay, so next time we'll talk about aspiration and retraction for about the first hour or so, and then there's a schedule of first 23 or 24 minutes. And if you're having a problem with a certain position, that's what I want to hear. And I see if I can correct it. Okay? Thank you.
I don't know if you all noticed on the back of the sheet, there's a survey for you. I forgot to mention that. It looks obvious, but in case you didn't notice it,